Okay, good evening, everyone, and welcome to the first Waxing Clinical of 2024, sorry. We're very excited to be kicking off this year with a very interesting topic. We've got two great speakers, and we're looking forward to delving into this month and next month where the focus is going to be on maternity. So joining us today, we have two clinicians from Netcare Park Lane. Dr. Paterson will be starting off the conversation looking at recurrent UTI. Dr. Paterson is an obstetrician-gynaecologist with a subspeciality in urogynaecology. She also holds a BSc in genetics, and she practices out of Netcare Park Lane Hospital. Following her will be Dr. Francois Retief, and he will be speaking on the complications of mesh and prolapse surgery. Dr. Retief is also an obstetrician-gynaecologist with a subspeciality in urogynecology. He also works as a lecturer at the University of Wits and a consultant at Charlotte Macleay, and is also practicing out of Netcare Park Lane. So thank you both for joining and for presenting on these really interesting topics. I'm going to hand over now to Dr. Paterson, who is going to kick us off. Please note to just stay on mute and video off throughout the presentation. And if you have any questions, you're welcome to post them in the chat. We will attend to the questions in the last 10 to 15 minutes of the session. Thank you.
Hi there. Thanks for having me. It's a real treat to be here. I'm going to be chatting a little bit about recurrent urinary infections, and we will definitely get to that in a second. But to start off, I just want to give a little bit of background about where we're coming from with this. So we all know that the bête noire of the gynecologists, and certainly the urologist and probably the GPs as well, is this patient who comes with a discharge, some kind of itching or burning or unpleasant odor. It's one of those things that it becomes really difficult to treat, as you know, as everybody knows. The reason that this topic has become so interesting is that we are finally getting an understanding of the human microbiome, which is a group of microbial genomes in a specific environment. And the Human Genome Project has recently analyzed the composition of bacterial communities in several human body niches. For example, most interestingly to us, the vagina, but also the urinome, and also in the gut. And you can see here, this is just a slide to show how interesting it is, how many of the microbiomes we share between species and between niches, and also how many are really quite unique between each microbiome. The reason I want to talk a little bit about the vaginal microbiome is that I always envisaged the vaginal microbiome as a moat, or like the bastion of infection for both the vagina and also for the urinary tract. I mean, the vagina is a very underappreciated organ. It's not just for having babies and all of those things. There are much more important things that the vagina does for us. And those things, you know, it can profoundly affect the health of generations. And this is generally due to the microbiome. So why do we care about the microbiome? There are millions of reasons. You can see how interesting it is. This new area of study is going to be just fascinating in the next few years. But particularly in our setting, we want to talk about the urobiome, which is the urinary tract infections, because that's why everyone's here. But you can see there is just a myriad of things that we are going to finally sort of start coming to understand on a molecular level now that we have a bit of sequencing of the genomes. So the Human Genome Project has found 5 sort of typical community state types of vaginas. So I always say to people, you know, you have people on this side, which is your group 1, which have an extremely, extremely stable microbiome. So these people can walk around survivor style with a wet costume for 2 weeks, and everything is absolutely fine. They don't get any sort of thrush, no infections, nothing. And then you get people on this side, which is your group 4 and 5, who are extremely unstable in a microbiome, and they can't even look at a jacuzzi without getting something. And then most of us sit somewhere here in the middle, and it takes about like 2 or so hits to really sort of get some kind of abnormality in the microbiome. So either you're very stressed or something else is happening, and then you have intercourse and the seminal fluid interacts with your microbiome or whatever it is, and then the microbiome starts to dysfunction. The problem is that we can push ourselves either way as well. So if you are repeatedly taking antibiotics, repeatedly taking flagyl, douching, you are going to disrupt your microbiome such that you are going to push yourself more and more towards this unsteady state, and your own innate immunity is going to be able to do less and less. So let's just take a little look at the next slide. So this is just a little bit in more detail. You can see that the healthy state is group 1, 2, and 3, and that's sort of lactobacilli dominant. Those are the more stable subtypes. And then you get sort of the transitional sort of dysbiotic sort of states heading from 3 to 4 and then 5. And then obviously, you know that the most dysbiotic states are going to be your ones where you have got a low lactobacilli count, but also you've got a high sort of other count like Prevotella, Gardnerella, you know, all sorts of other things that we really, we want to be there, but not as the main sort of factors in our microbiome. So another way to look at it, which is like quite a nice way of thinking about it, is that if you think of the vagina as a rainforest, and I like that analogy because it is quite a special. I mean, the vagina is very unique, and it can also get a little bit steamy. So we also like that analogy. But basically, if you can picture this, remember that in a rainforest, you have trees with an overstory, and then you have this understory here, and these are smaller plants and weeds. And this understory is sort of kept in check by this overstory. So if you picture the lactobacilli as the sort of overarching sort of umbrella that just is going to keep everything else in check. So your Candida and your E. coli, all sorts of things are supposed to be there. They're in the understory, but they're supposed to be there in small amounts. And the problem is it's a proportional thing. So that's why it's very difficult to see on a vaginal swab what is going on. I mean, if you do a vaginal swab at any given day, you're going to see all of those other species. But a vaginal swab doesn't give us an idea of what's happening actually in terms of proportions. And then just another little part of the analogy, the vaginal estrogen is the sunshine that keeps the lactobacilli working. So without good amounts of vaginal estrogen, the lactobacilli starts to dysfunction. And you can really see that when you look at the postmenopausal microbiome. So, you know, this is the reason why we have an increase in urinary tract infections in the menopause. You can see that with less estrogen, the vagina starts to atrophy, you get less lactobacilli, the pH increases and becomes more alkaline, and the vagina actually becomes predominated by and colonized by E. coli. But it's not all doom and gloom, because intravaginal estrogen, like just normal Vagifem, for example, can significantly decrease the incidence of UTIs in postmenopausal women. You know, what they found is that with a good amount of vaginal estrogen, you can actually get you can actually note a significant reappearance of lactobacilli after 1 month, and a significant decrease in the pH again with just normal topical vaginal estrogen. So you can see this can go a long way on its own just to prevent recurrent UTIs in postmenopausal women. So this is really just an interesting little slide. It's nothing that you need to know, but the important part of this is that lactobacilli does a lot in the vagina and obviously in the gut and other places. I mean, it produces antimicrobial, antiviral, anti-cancer, all sorts of compounds. It prevents adhesion of other bacteria. It competes for nutrients and binding sites for the nasty bacteria that we don't want to get out of control. And it also modulates the actual immune system of our host. So it induces cytokine production and does a whole lot of other things that really are quite important. And without lactobacilli, and certainly if you are injudicial in the use of your antibiotics, you are going to interfere with the sort of innate immune system that is going on. So I always like to say we need to sort of reframe this problem. So instead of saying this is an infection, you know, even with Candida, you say you've got an infection, it's Candida. It's not an infection. What it is it's a disruption of the normal microbiome, the normal homeostasis, which leads to dysbiosis, and you get dominance of a pathogen which isn't supposed to be dominant. For example, Candida. Some people are more susceptible to Gardnerella, and then they get that funny discharge with a fishy smell. Some people it's E. coli, some people it's Candida, and some people it's other things. But you get this overt dominance of a pathogen, and then you get what we call clinical infection. But it's not so much an infection as an overgrowth or a disproportion. So because we are here to talk about urinary tract infections, let's take a look at the urobiome specifically. So we know that there is a urobiome, and we've done some genetic sequencing, but we still are not 100% sure what exactly the urobiome is composed of. The bladder, we know, is a low biomass environment, but we also know, which is very interesting, is that the prevalence of certain bacteria in the urobiome may predispose us to some urinary diseases. So you can see it might be a little bit small, but for example, urgent continence, we've found that there's a dearth of lactobacilli and an increase in Proteus and Staphylococcus. And they're very, very interesting. In UTIs, in people that are prone to UTIs, we often see a decrease in most of the things: atobium, Gardnerella, lactobacilli, Smithia, all of those, we see a decrease. So it's quite an interesting, I think the point of the slide is that we need to realize it's not going to be as simple as slinging antibiotics at people in the next couple of years. What we need to realize is that there is something to do with how all of what we've normally said are parasites are interacting with each other, and either protecting us or not, depending on where we are. So you can see this is a simple example, but for example, if we look at overactive bladder, we know that the microbiome could be a causative factor, because in overactive bladder, we've seen a strong decrease in lactobacilli and a huge increase in Proteus and Staphylococcus. We also know that it informs our treatment choice, because we know that Botox and antimuscarinics, which are some of the treatments for overactive bladder, are much better in individuals with low biodiversity. So that's the microbiome as well. And we also know that it affects our treatment efficacy, because this urobiome modulates the bladder-brain pathways and affects the signaling to the brain, which will tell us, like, if you have a abnormal or an aberrant signaling to the brain, you might feel the symptoms more acutely or less acutely, depending on what your microbiome is made up of, which is really quite fascinating. So if we look at the next slide here, this is just a little thing. So the standard definitions of recurrent UTIs are more than 2 infections in 6 months, more than 3 in a year. We also need to be very sure what we're looking at. Is this recurrent infection? Is it reinfection with a reservoir of pathogens somewhere? Particularly reinoculation of a UPEX. Is it relapse? Are we looking at atypicals? So classic techniques we know with agar can't detect all anaerobes. Certainly they don't detect bacteria and biofilms, and some commensals and symbiotes, and Corynebacterium, ureaplasma, all of those are not picked up on your standard agar. So we need to bear that in mind when people keep getting these recurrent infections, and we have to look at the antibiotic use. It's also important here that we make sure when a patient comes in and says, I'm having a recurrent infection or I'm having a urinary tract infection, that we don't take them at their word. And this is not because all patients lie. I'm not house, but I do think that patients are often confused as to what the symptoms are. So often when someone says it burns when I wee, it means that it burns the vagina when urine touches the vagina. That's very different from the typical spasm, that post-void spasm that you get of dysuria with the urinary tract infection. And people are very confused between Candida and urinary tract infections. So it's up to us to really pick apart what they're feeling, because otherwise you're going to be treating this infection. And if the patient is actually having Candida, what you're going to work up with is you're just going to keep on making it worse, because antibiotics we know are going to interfere with the microbiome, and you're going to get a massive influx of Candida. So what are our risk factors? So we have always been taught traditionally that, it's a hygiene thing. You need to wipe from front to back, and you need to avoid your bladder. Traditionally, I think this has also gone a long way to making people feel a bit dirty when they've had a UTI, which I think is very disingenuous. They found that there's absolutely no correlation between pre or post-coital voiding, a frequency of voids, delayed voiding habits, wiping habits, douching, hot tubs, BMI. None of that makes a difference. In fact, the strongest independent risk factors for UTI is sexual intercourse. And that's also because, obviously that seminal fluid is extremely alkaline. And we know that the lactobacilli likes a nice acidic environment in which to work, and you get an overgrowth, obviously. And it's really quite interesting that you can see that there are so many other risk factors that make us susceptible, which we can go into in more detail if anyone is interested to the TAM about the TAM horsefall protein and non-secretor phenotypes, etc., etc. So this is why it's so tricky for us to treat, because bacteria have got all these tricks up their sleeve, and they have all these interesting things that they do to us, and they sort of get around our own innate immune system. And this is why the lactobacilli is so important, because it has all of those stepwise sort of methods of being able to sort of combat the expression of Fimbriae, the production of hemolysin, the urease production, increased motility. We need our own innate immune system to be able to fight off these bacteria. One of the main bugbears of UTI diagnosis is dipsticks and urinalysis. So it's important that we recognize that dipsticks particularly are not very, very helpful to us. There's no real benefit to external cleaning. We know that even in normal MCNS samples, more than 30% of those samples are contaminated. And we know also that if there's been in a little specimen jar for more than 2 hours, the entire test becomes quite unreliable. Important to also note, I mean, I know that a lot of people rely on dipsticks, but once you've had a week of exposure of a dipstick to air, up to a third of strips provide a false positive for nitrites, which is crazy. You also have, a lot of other false positives and negatives, which we'll go into in a moment. The other important thing to remember about MCNS is that we need to have a significant amount of colony forming units. And that's the accepted criterion that's been repeatedly validated. The important thing to remember as well is that for Staph saprophyticus and for Candida, 10 to the power 4 colony forming units is actually appropriate. Sorry, I've got a little feline interloper here. I'm just going to push her away. Okay, so talking about asymptomatic bacteria, that means that we've got more than 10 to the power 5 colony forming units in 2 consecutive samples. It's very rare. And basically, in the absence of renal abnormalities or diabetes or dialysis, we really don't see it. So if you are seeing such a thing, it's important that we do look for those factors. And the only time we actually treat it is group B strep, and that's in pregnancy, obviously. And that's because in pregnancy, the urinary tract actually dilates quite a lot, which allows the bacteria to ascend. Otherwise, we're going to be looking at acute pyelonephritis, which obviously will affect your pregnancy and cause preterm labor. But not just that. Obviously, we also don't want people to deliver with florid group B strep because that can cause congenital pneumonias. The other side of the coin is symptomatic A bacteria. So when a patient presents with this, where you're just getting repeated MCNSs that are not coming through, and this patient is driving everyone is at their wit's end because she feels like she's going crazy and being gaslighted because she's having all these symptoms. You feel like she is actually crazy because she's got all these symptoms, but nothing is coming up. You must think of the atypical bacteria, Haemophilus influenzae, parainfluenzae, pneumococcus. All of these need special media in which to grow and actually to be able to pick them up. One thing that we have always sort of looked at is contamination. So, contaminants are a big deal when we're dealing, because obviously the microbiome is full of other bacteria. You can overcome it by catheterizing patients. That is something that one can do. But it is important to remember that polymicrobial infection is quite rare. generally you have one dominant organism and you have lots of leukocytes or white blood cells, more than 50. And if you have a lot of squamous cells, that's generally an indicator of some kind of contamination, not always, but often. So you have to look at the patient as an entire clinical picture. Look at the leukocytes, look at the colony forming units, look at how many times she's been in, look at the symptoms, and then obviously check the amount of squames in your sample, because that also will give you a clue to what's going on. Some common pitfalls in the diagnosis of urinary tract infections, particularly when you're looking at leukocytes. It's important to remember that leukocytes can persist after infections. And if you have a urine with a very, very low osmolality and you have pH values more than 6, you are not going to see leukocytes in the erythrocytes because they're going to be lysed. So it's quite interesting that we always sort of like take a urinary sample, and patients will often give you a urinary sample that they've taken this in the morning. By that time, when you've had such a delayed analysis, it probably isn't really going to help us much. The other thing that people are quite obsessed with are these nitrites. So we must remember that nitrites are highly specific for gram-negative bacteria, and not everything that causes urinary tract infection is a gram-negative bacteria. So what should we do? We should always, with a patient with recurrent urinary tract infections, culture and get a culture and sensitivity. You can give interim antibiotic treatment. Nobody says that it's reasonable to expect a patient to have severe urinary tract symptoms and you're waiting for the sensitivity. But it certainly is something that you need to make sure that you are treating the right bacteria and that you are actually treating a bacteria. And persistent symptoms, you need to repeat the urine culture. And I always, with patients with recurrent urinary tract infections, like to do a follow-up MCNS after they've finished antibiotic treatment, so 2 to 3 days after, just to make sure that we are actually dealing with a urinary tract infection that has been cleared and not something that is just simmering. When we look at guidelines, the recommendations say obviously uncomplicated pyelonephritis, you need a short admission and courses of fluoroquinolones. You should only reserve hospitalization for parenteral antibiotics until the patient can be converted to oral routes. We're going to talk about that now. The other thing I wanted to really state here before we even go into antibiotics is that a lot of the societies, including the European Association of Urology, has really sort of driven home the fact that we should start in our treatment with risk factor avoidance, then go to non-microbial measures, and then look at antibiotics prophylaxis. So we need to. I know it's irritating when patients come in with these things, and I know people are not always very adherent to their vaginal estrogens, etc. But it's important that we really, really try and get our patients to be adherent with these things, because we can avoid all of this altogether. So this is just a slide. I'm sure everyone has got this, but we're going to just go swiftly along from here. But I think everyone knows that in general, your first line, so your fosfomycins, your macrodantin, nitrofurantoin, and your Bactrim. And I mean, these guidelines are everywhere. We don't really need to go into them too much. It just is important to remember that with a low GFR and hepatic dysfunction, or in pregnancy greater than 38 weeks, we must avoid macrodantin. And we must also remember that there are a lot of things that we need to be wise to in a pregnancy. We cannot just prescribe antibiotics willy-nilly, because it's going to have an effect on either the fetus or the pregnancy itself. So, as I said, in pregnancy, avoiding nitrofurantoin, augmentin in the later part of pregnancy, because it causes necrotizing, or it can cause necrotizing or predispose to necrotizing enterocolitis. And I think that Bactrim is known to be a folic acid antagonist, which is not a huge deal at the end of pregnancy, but still it's important that we are aware of these things. So this is a very interesting little slide, because it gives us a good idea of what we should use for prophylaxis. I'm happy to share these slides with anybody. I don't think we need to go through them, but prophylaxis is something you must reserve prophylaxis for a patient who knows what the precipitant is. So you can do the continuous prophylaxis, but the problem with that is that you're actually going to be you're going to be in the same boat, because you're still going to schmitz your microbiome. And when you do that, you are going to predispose this patient to further infections, and you're going to end up with a patient who is older, who is continuously going to have this bladder that is colonized by really, really nasty bacteria that we can't really get rid of because the innate immunity is not working. So if you must reserve for postcoital or whatever the precipitant is, prophylaxis, which is generally a once-off thing. But if you do use these antibiotics, you must be very, 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 very careful that you're still using vaginal estrogen if necessary, if postmenopausal, and that you are replenishing your lactobacilli population with a vaginal suppository. So the non-antibiotic approach, as I said, risk factor avoidance for sure. Then should be our second line according to some of the guidelines. Cranberry, look, it's very difficult to get enough proanthocyanins into your body if you're just drinking the juice. That's why it has very poor adherence. But we really don't have that much evidence for or against it. It's not a huge deal if people want to take it. Vaginal estrogen, as we've already covered, is very, very, it's imperative if the patient is postmenopausal. Canefron is an interesting little medication. It's a diuretic and antispasmodic. It's an antibacterial, anti-inflammatory, nephroprotective bunch of herbs, essentially. And it does work quite well. It has quite good evidence behind it. So sometimes when you tell these patients this, you feel a little bit like a homeopath, but these things have good evidence behind them, and they do no harm, and that's really where we're coming from here. And obviously my main note here is probiotics. If we are going to treat these patients and allow their innate immunity to do what it is supposed to, we need to replenish that good lactobacilli, and it cannot be probiotics that you drink. It needs to be proper vaginal suppositories of lactobacilli, preferably with nothing else, although those sort of formulations have been quite difficult to find at the moment. So if you find, for example, that Femina, it's disgustingly named Cookie Fresh, it works quite well, but it does have boric acid, which is for Candida glabrata. I don't think it's going to do any harm. I think the main thing is just to replenish your microbiome. And then obviously, there is a lot of work going into immune stimulation with bacterial lysates given orally or vaginally. It seems to be effective if you have regular boosters. It's still in the trial phase. And then this is most interesting, and I can't find it that it's in the country yet, but it's certainly in a lot of other places. The science behind this actually won the Nobel Prize in 2010. It's a vaccination with whole cell inactivated bacteria of the 4 main trouble causes in the urinary tract infections. So E. coli, Klebsiella pneumonia, Proteus vulgaris, and Enterococcus faecalis. It's really quite interesting. And I mean, it's a daily spray that is pineapple flavored, so yum, but also has been shown to reduce the recurrence and sort of like occurrence of infections by about 80% in patients with recurrent UTIs. So it's very exciting. It's available in the UK. It's awaiting approval in Canada. I don't know. We'll probably get it in like a couple of years. I don't believe we're at the forefront of this. And that's it. So I know we covered a lot of things, but thanks for having me. I really appreciate it.
Thank you so much, Dr. Paterson. That was fascinating. Thank you. Yeah, very exciting. I'm looking forward to the Q&A. But without further ado, we do have a bit of a time pressure so we can get through the next presentation as well. So I'm going to hand over to Dr. Retief. Yes. There we go. It's a pleasure. Are you able to share your screen?
Let me try.
Perfect. And yes, we can see your screen. Thank you.
Okay, great. All right, so let me just get onto this. There we go. Right, so thanks everybody. I'm Francois Retief. I'm also a urogynaecologist here at Netcare Park Lane Hospital. It's a great pleasure to present this session together with Francis. We work closely together. We two of the first urogynecologists to qualify in our fairly new subspecialty via the examination route in Gauteng. And it's a great pleasure to work together. I always say we complement each other very well. She's smart and I'm tall, so we complement each other's weaknesses perfectly. So my topic is about meshes and slings. It's a little bit of a background on surgery for pelvic organ prolapse for something that's really can be a bit of a niche and is not that well known. But there's a relatively common problem with the figure usually quoted of one out of 11 women needing surgery for pelvic organ prolapse during their lifetime. And it's also a little bit of a history of surgical device development and adoption. And it's also a cautionary tale, which I think is where the fun of this talk comes in, because everybody enjoys a little bit of Schadenfreude and seeing someone else walking into the propeller. And this is where the urogynecologist went straight into it. Just a little plug. Yesterday happened to be International Urogynecology Day, which I didn't know, but I found it out yesterday and I thought it'd be interesting to share with you. So to get into the talk itself, just as an outline, I'm going to show you the context of the use of meshes and slings in urogynecology, and then talk a little bit about the clinical use, and then some technical aspects of the synthetic grafts, and then go through the history of how it came to be adopted, and then see how it all went wrong, what the complications and the controversies are, and then look at the current evidence base and what are the things that we are doing at the moment. And then finally, look at what the alternatives are to meshes and slings, and a little bit about what the learnings are and what the lessons are we can take from this, what turned out to be a public health debacle. So the context being that a large part of urogynecology practice consists of prolapse and incontinence. And both of these are due to structural and support deficiencies of the pelvic floor, which you can repair with native tissue, but unfortunately they've got very high rates of recurrence. And synthetic materials can be used to surgically reconstruct these pelvic floor supports. But turns out that they have significant complications, and the scale of which only became apparent after widespread use. And regulatory bodies then came on board, investigated, and then curtailed the gynecological use of synthetic mesh. Just to give you the context, in 2018, so a couple of years ago, NHS wrote to all acute trusts immediate implementation of a high vigilance restriction period for vaginal meshes. And in April 2019, the FDA ordered all manufacturers of surgical mesh intended for transvaginal repair for both anterior and posterior compartment prolapse to stop selling them. So something that really became quite serious. The clinical use, so first, mesh that's used for pelvic organ prolapse. So there's 3 levels of support for pelvic organs and for the vagina. For the anterior and posterior compartment prolapse, repair is aimed at the so-called level 2 support that was described by Delancey, one of the fathers of urogynecology. And then for apical prolapse, that's if the uterus itself or the vaginal vault in a woman who's had a hysterectomy prolapses, then level 3 support needs to be replaced. And then vaginal mesh was introduced that you can place that aims to provide support for all of these to reduce the unfortunate high failure rates of native tissue repairs. And we're talking of something on the order of about 30% of failure, subjective failure within 5 years, which is really quite high. When it comes to incontinence, so stress urinary incontinence, the so-called hammock theory is that you've got fascial and muscle support underlying the urethra in the female, and that when there's a stress or increase in intra-abdominal pressures, these supports allow the urethra to seal and therefore prevents leaking during cough or sneezing. I mean, you can try it now, give it a little cough, and you'll feel your pelvic floor contract. But when this support fails, that can then result in stress incontinence, which is something that can be relatively mild, but it can also be quite debilitating, especially in younger women, where this prevents them from exercising, which we know is, of course, one of the key joys of life, and also something that helps with weight loss and general well-being and so on. So this is something that can really affect quality of life. And so you can do this native tissue repair, so-called corpus suspension, or mid-urethral slings using native tissue fascias, or you can use a synthetic tape. And this tape can be placed either retropubic or through the obturator foramen. And these two little pictures show the difference between these two. So the blue being the tape here, it slings underneath the urethra and it goes retropubic, so behind the pubic bone. The transobturated tape goes to the sides and goes through the obturator foramen. It's a little bit confusing, the terminology. So you get lots of different three-letter acronyms for these procedures. So mid-urethral sling is sort of an umbrella term for both of these. So-called TVT is the tension-free vaginal tape, and that actually also covers both of them. But then we distinguish between retropubic tapes and transobturated tapes. The history of these, so native tissue repairs in 1940, Kelly described application, and then Marshall, Machete, and Krantz in 1950, 1961, a variation of this, the Birch corpus suspension, which was updated in 95 to be performed laparoscopically. Also a long history of use of graft, so the so-called gauze hammock in 1968. In 1996, the retropubic tape was first described. In 2004, the transobturated tape, and in 2006, the so-called single incision mini sling, which is similar to the transobturated tape, only difference being that it stops at the obturator foramen where it anchors onto the fascia with little anchors, and the tape doesn't pass through the foramen itself. When it comes to the vaginal meshes, they've got a bit of a shorter history. They were approved in 2005 by the FDA under the so-called 501(k) rule, which is a shorter route to approval if you got something that's substantially similar to an existing device. And at the time, they were considered similar to meshes that were used for abdominal hernia repairs, which unfortunately was not correct, because the meshes placed for abdominal hernias is placed on the peritoneal surface. It's far away from the skin, whereas vaginal meshes gets placed just underneath the vaginal skin, quite close to the surface, and also is placed right next to hollow viscera, either next to the bladder or next to the rectum, where there's potential for some mischief. And then there's an exception. So this is also just to give you context. Those vaginal meshes get placed through a vaginal incision, so vaginal surgery. Then there's the so-called sacrocarpopexies or sacrocervicopexies or rectopexies. This is an abdominal procedure, which nowadays is also most often done laparoscopically, where a Y-shaped mesh is fitted over the top of the vagina or onto the front of the rectum in the case of a rectopexy, or to the back of the cervix in the case of a cervicopexy. And this then gets attached to the median ligament of the sacrum using tacks or sutures. These meshes have got much lower rates of complications. They were first described in the 70s. They aim primarily at correcting apical prolapse, but can also work quite well for anterior and posterior compartment prolapse, depending on how far the dissection gets carried out at the time of surgery. But they've got a low risk of erosion because they're placed abdominally, and therefore provisionally they've been spared from the regulatory scrutiny that the other meshes are subject to. So technical aspects of meshes, I mean, one can go into this in a lot of depth, but these meshes are grafts. So a graft is any foreign material that's implanted in the body, and it can be biological or synthetic, and then so-called homo-alloy xenografts, depending on whether you get your graft from yourself or someone else or from an animal. And then the synthetic grafts can be divided into absorbable or non-absorbable. This is quite a nice micro photograph of what these meshes look like. So it's polypropylene threads that get braided into a so-called macroporous mesh. So the terminology, which also can be a little bit confusing. So slings, which we use for the stress urinary incontinence, they are tapes which are also meshes. They're really the same meshes as we use for that get placed transvaginally. And the so-called vaginal mesh is, in fact, a graft that is made of mesh. And the mesh is a material, like we said, that's made out of thread. There's a mesh classification that was initially in the context of hernia surgery, relating to the size of the pores. Don't need to go into too much detail. The important thing to know is that we use the type 1, the macroporous, the ones with the big holes, because the microporous meshes have turned out to be truly horrendous in their complications. So the majority of meshes that we use is the type 1 proline meshes. So proline being polypropylene, which is a non-absorbable monofilament material. So after these meshes started being implanted, the complications and the controversy started. So early complications, bleeding and infection and so on, but then the devastating long-term complications. And this picture here shows you, quite simply, this is a mid-urethral sling that is eroded through the vagina. You can see there's the urethral meatus, the catheter going through, and then probably like about a 1 square centimeter area of mesh that becomes exposed here, which doesn't seem to be such a big deal, but my, oh my, does it cause problems. So chronic discharges cause chronic pain, dyspareunia, and then the cutesy term of hyspareunia, which refers to discomfort to the male partner during intercourse. And then once you've got mesh erosion like this, these things are devilishly difficult to remove. You can imagine with a transobturator tape, this goes underneath the urethra, to the sides, through the obturator foramen, which is no man's land for any surgeon. You don't really want to go there. And then through the adductor muscles, where they can cause chronic groin pain. So to go and excise these things are quite difficult. And then the lawsuit started. So you can see this went pear-shaped quite quickly. In 2005, these meshes were approved. First case successfully litigated only 7 years later for the $36 million. Johnson & Johnson lost their first case in February 2013. Largest settlement to date in excess of $70 million. Thousands of lawsuits and settlements made their way through the US courts. And then in an ironic twist, for if you've ever been the subject to a medico-legal thing, is that the plaintiffs have now started suing their lawyers, which I say is like sharks eating other sharks. But this is an advertisement from the US where a law firm is investigating mesh settlements in which lawyers for victims may have failed to recover all available benefits or may have charged clients too much in fees and expenses. And they are committed to pursuing these claims. So things are really becoming a total free-for-all with the meshes. And of course, it's reached South Africa now as well. We're always a little bit later, but true as Bob, 10 years later, April 2023, it even made it onto carte blanche. There's a class action lawsuit, 2 different law firms that are pursuing this against Johnson & Johnson, Coloplast, New Angle, and Ethicon. Because, of course, in South Africa, we had enthusiastic use of mesh in the private sector and sort of the mid-2000s to the mid-2010s, after which that enthusiasm started to cool a little bit once people started getting into the complications. So the FDA journey in the US, once the problem started, is first caution was issued in 2008, 2011, upgraded to a warning. In 2012, ordered post-market studies of efficacy. Jan 2017 reclassified mesh from class 2 to class 3, which means they require post-market studies into safety. And then July 2018, stopped selling posterior compartment meshes. April 2019, all vaginal mesh sales to be halted, pending submission of data proving safety, which to date has not been forthcoming. So I don't think this is going to turn around. In the UK, something similar in July 2018, a suspension period for the use of all vaginal mesh, which was introduced. And they may only be used under very specific circumstances by trained surgeons with evidence of surgical volumes and reporting of adverse events. Scotland and Ireland have followed suit, and that pause has been extended and is still ongoing. And then, of course, patient activism also came on board. There's several patient activist groups. This picture is from a group called Sling the Mesh, which is the best known one overseas. It's become a highly emotive issue. If you go onto these websites, you'll see some patients claiming highly unlikely, if not downright impossible, adverse events. But this is now the major source of information for the public. So this has become quite a toxic conversation to have with patients if you are intending to place any meshes. And this is just some examples of the quite dramatic things that are on these websites, raising awareness of the life-changing risks of a simple day case procedure, and quite dramatic using hooks, and lots of pictures of women being almost completely debilitated by the use of these meshes. So then the most definitive treatment of mesh complications is excision, and this can be, like I said, extremely invasive and challenging, and has given rise to a new and was probably going to be quite a transient specialization, which is mesh excision surgery. There's centers of excellence in the UK, Australia, and the US, and the last presentation I listened to from a surgeon in Australia is they really try and remove the meshes completely, for psychological reasons as much as for clinical reasons. Once patients feel that they've been harmed by meshes, they want to see it all removed and see it removed completely. So the current evidence base, and this is now where it stopped. This was about 3 years ago. Nothing new has really come to light, but the Cochrane reviews that look at meshes. For pelvic organ prolapse, the outcomes in question one can look at is reoperation for whatever reasons, awareness of prolapse or subjective recurrence, demonstrated prolapse or objective recurrence. And this speaks to how well this works. And then looking at the adverse events, including mesh exposure, new onset stress incontinence, new onset dyspareunia, and quality of life scores. For stress urinary incontinence, for the slings, the comparisons are not so straightforward. The high quality evidence we have just compares the different type of slings to each other, but there's still some take-home data from that you can use to inform discussions with patients. And so the evidence on mesh for pelvic organ prolapse efficacy, a 1 to 3 year review, in women who had native tissue repairs, 19% of them had awareness of recurrence versus 10 to 15% for women who had mesh placed. So the mesh does perform better. Repeat surgery for prolapse is also lower, 3% in native tissue repairs, 1 to 3% in women who had meshes. But then repeat surgeries for all causes, so mesh exposure being the big one that makes a difference, 7 to 18% in women who had mesh placed versus only 5% in women who had native tissue repairs. And then objective prolapse, so this is what you can demonstrate clinically, but which may not be bothersome. And this shows you the high rates of recurrence in native tissue repairs, 38% in native tissue repairs versus 11 to 20% in women who had meshes placed. When it comes to the adverse events, so mesh exposure, there's a high rate of bladder injury when meshes are placed. Surgery for mesh exposure is required in 8% of women, this is really the reason why this was stopped. This is unacceptably high. A little bit more new onset stress incontinence, but interestingly, no, it doesn't seem to be any difference in new onset dyspareunia or quality of life scores. And there's a trend that the operations take a bit longer when meshes are placed. And this is a little bit of a busy slide, but I'm just going to take you through basically what we said. So awareness of prolapse in native tissue repair, about 18% of women, a lower number, 12% of women when they had transvaginal meshes. Repeat surgery for prolapse, double the rate if the mesh wasn't placed. Repeat surgery for continence, about the same between the two. But then if you put them all together, and the big one being then mesh exposure, 3 times more women need repeat surgeries after mesh being placed because of those mesh exposure complications. And then recurrent prolapse, again, you can see much lower in the mesh group. So again, it works, but on the balance of things, there are lots of drawbacks. And then with other things, so bladder injury also higher when you're placing mesh, dyspareunia about the same, new onset stress incontinence more or less the same. When it comes to the tension-free vaginal tapes, so lots of trials, 12,000 women, but two key take-home figures here. It's a very efficacious surgery, over 80% cure rate. And I mean, cure is defined as being absolutely dry. And these women who sometimes cannot skip rope, got to cross their legs when they sneeze, etc. And this is after 5 years. So this is quite durable successes. But the rates of tape erosion is about 2%. So 1 out of 50 women is going to have one of these potentially quite devastating complications. And so the lessons and the conclusions from this whole debacle say, yeah, this has clearly been a debacle and lots of fingers have been pointed. The take home is that even though there is some potential benefit from using these synthetic grafts, the fallout from the complications has really put an end to this intervention. It's hard to assign blame. So is it industry that were pushing these things too hard, that were encouraging surgeons to use things that they weren't fully trained to use, they didn't have the appropriate experience for? Was it surgeons who were over-enthusiastic? Was it patients who were pushing to have things done when they got frustrated with recurrent failures? Or maybe it's probably the truth that it was all of us are a little bit at fault. However, in the courts, it's mostly been the manufacturers who have suffered liability. And this is an important point. So it's illegal to sell these meshes in the UK and in America, but a surgeon can take a piece of mesh, a hernia mesh, and fashion it into something and place it vaginally if you want, as long as you counsel the patient appropriately. But the point being that the legal fault is followed where the money is, and that's why the manufacturers have mostly withdrawn from the market. And this is a cutesy little graph that often gets cited with this. This is the Gartner hype cycle of technology adoption. It's widely quoted, where you've got technology introduced, there's a peak of inflated expectations, and then there's a trough of disillusionment if it doesn't work as intended, and then there's a learning curve, and then there's a plateau of productivity. But to use this graph for illustration, the peak of inflated expectations was probably too high, and the trough of disillusionment is probably too low, that there's not going to be any slope of enlightenment, and there's not going to be a plateau of productivity. So in reality, the days of transvaginal mesh for pelvic organ prolapse are numbered for any but very few subspecialists. And I strongly suspect that in probably 5 or 10 years' time, this is not something that's going to be done at all anymore. The future of the mid-urethral slings is uncertain, but it may follow the same route, which would be a pity because this is really a very good intervention. But there may be a future for judicious use of mesh. And there's some alternatives that are being looked at, including biological grafts, homografts, lab-grown homografts. Interesting with the homografts, there's a group in the Netherlands that use the iliotibial band, harvest that from the leg, and then use it to fashion a mid-urethral sling, which is, of course, a homograft, and then is less likely to cause problems. Our current options for prolapse surgery are native tissue repair or the abdominally placed mesh, the so-called sacrocolpopexis. And thank you very much for joining me on this roller coaster ride through real drama. I think we'll be happy to take some questions now.
Yes, 100%. Thank you so much, Dr. Retief. That was absolutely fascinating. So just to everyone on the meeting, you're welcome to either ask your questions in the chat. And there's actually one question that's come up already. And the question is, now that we know that meshes are not great for prolapse, what should a general practitioner dealing with a patient tell their patient?
Yeah, I think it's good to be aware of this because people will ask you these questions. Like I said, once something's on carte blanche, it is out there and people are going to ask this question. And then we have this conversation fairly frequently when we have women who have prolapse, and if we're planning the abdominal sacrocolpopexy where the mesh use is acceptable, but they've got this reluctance to use it. I think it's good. We've got a duty of candor to patients and to say to them, but look, there was this use of mesh that was injudicious and it caused a lot of complications. If we do use mesh or if we do place a sling, we've got to be very clear about what the potential complications are, and do proper consent.
Thank you. And then another question for Dr. Paterson. You mentioned in your presentation a natural solution or a herbal solution that could be used as a prophylactic measure to prevent your current UTIs. Can you just maybe share a little bit more about that, and in terms of, how would you sort of approach that conversation with the patient in a consultation?
I think probably you're referring to Canefron. So Canefron is, you can get it from any pharmacy. It's rosemary, something called lovage, and some other herbal concoction. It is very safe. It's got enough safety data to tell your patient, look, it's very, very safe. What I say to people is that we need to look at them holistically. We need to look at them as their entire patient, not just as their bladder, not just as their bladder with E. coli. And, when we're dealing with these things, because we're looking at holistically, we need to say to them, look, it's not just now with an antibiotic, it's continual prophylaxis, and it's preventing this happening again. And most of the time, when people understand the underlying reasoning behind it, and when you appeal to the fact that actually there's a scarcity factor here, like if we don't do this, you may be sitting in a couple of years with something that is much worse. Generally, patients are reasonable. They want the help. So I will just say to them, this is a herbal supplement. It sounds a bit like hocus pocus. It has good evidence behind it. Let's give it a try.
Okay. Thank you so much. And then for Dr. Retief, another question around, so in the numbers that you mentioned around the repeat surgeries for mesh, understanding sort of the complications that you've mentioned, but how much of that number was influenced perhaps by the increased litigation and sort of the public scrutiny on the procedure versus true actual complications from mesh surgery?
Oh, that's a great question, but it's quite loaded, so I couldn't give you the answer for that. I think there's definitely going to be, and I mean, I might sound a little bit flippant, but when these things cause complications, these women really, really suffer. But there may be an aspect of once you've got a small complication, becoming aware of it, going onto the patient's group, really feeling that you've been harmed by having these meshes placed. And I think that comment that my colleague from Australia made, saying that, the complete excisions are done more for psychological reasons than for clinical reasons, I think speaks to that. And she said that it's also important to show these women the mesh, and they want to see that it has been removed. And I think one can debate the rights and the wrongs of this, but I think what you've got to understand that this is a reality, and this is what patients feel and what they think, and I think we have to respect that.
Can I also just add here? I think a lot of the problems with the mesh, not only that was injudicious use, a lot of the problems come in with poor informed consent. And I mean, if you listen to a lot of the complaints, it comes from people not being told, once mesh is in your body, it is never, 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 never coming out. And I think people are willing to take complications, but they are not willing to deal with or sort of even contemplate complications that they were never spoken to about. And I think that's what has made people so voracious about this, and what makes people feel so violated with this mesh. It's almost like it's a violation because you weren't told that this was going to happen. People can deal with a lot of things. Erosion is not a huge deal. A vaginal discharge is not a huge deal. I think a lot of the time that anger and that hurt comes from the fact they weren't spoken to in this sort of and given the autonomy to make an informed decision.
Thank you for that. I'm going to take the last question. I do see we are at time, but there was just one last question in terms of for patients with recurrent UTIs, how often or would you consider referring them to a public for physio?
So if you think that a recurrent UTI is from a structural issue, so if you think the patient has prolapse, then for sure you need to go to the physio. And, you know, if you think the patient's got a mildly neurogenic bladder, anything that's going to interfere with that bladder emptying is going to leave urine sitting around in the bladder, and it is going to be a nidus for infection. So if you believe that the patient is not emptying their bladder, definitely pelvic floor physio is a must. Pelvic floor physio is probably a must for anyone with the vaginal birth, but I think particularly for people like that, it's really great. But I don't think that in the absence of a patient voiding and having a normal post-void residual, I don't really think that specifically for the UTI, it's going to have much benefit.
Okay. Thank you, Dr. Paterson, Dr. Retief. This was a fascinating start to the conversations this year. Thank you for two excellent presentations. We have had some people requesting the presentation, so I'll reach out to you guys after this meeting. But thank you for your time. Thank you for everyone who joined, and have a lovely evening further.
Thanks so much.
Good night.